I want to welcome everybody to SFS Online and On Topic. My name is Tony Arend. This webinar is produced by the Georgetown University Alumni Association in collaboration with the Walsh School of Foreign Service. Over the next several weeks, we're going to be bringing in distinguished faculty and alums to talk about some of the most critical issues of our time. Today, we're especially honored to have with us Professor Rebecca Katz. Now, you may look at Professor Katz and say, I think I've seen her before. Professor Katz has been very much engaged in all the conversations about COVID-19, so you might have seen her on CNN or some other outlet. Well, we're honored to say that she's here with us today. Now, Professor Katz is going to be talking about COVID-19 and global norms. Let me just tell you just a little bit about her. She is a professor at the Georgetown University Medical Center and the Walsh School of Foreign Service. At the Medical Center, she's director of the Center for Global Health Science and Security. She's a specialist in global health diplomacy, global health security, and emerging infectious diseases. She has advised the Department of State. And one thing to note, last year, and this may have been prescient on her part, she convened the first international scientific conference on global health security. She brought together about 900 participants from all over the world, and she's planning to follow this up in 2021, and we hope there can actually be a real in-person conference in 2021. Dr. Katz did her undergraduate at Swarthmore College. She has a master's of public health from Yale University and a Ph.D. from Princeton University. Now I'm going to turn it over to Dr. Katz in a second. She will then present. After she presents, I may have a couple questions myself to ask. We'll then open it up to questions from the broader audience. I would ask that you put your questions in the question box on your control panel, and Kelly Young of the Alumni Association will then read out the questions and Dr. Katz will respond. So, Rebecca, hold forth.
Wow, okay. So thank you for having me. Thank you for the opportunity to speak with all of you today. I think I used to have to spend a lot of time explaining why somebody who has a research center in the medical center also teaches in the School of Foreign Service. I'm hoping I don't have to do that as much anymore. And I think a lot of people who maybe have humored, I don't know if humored me, humored my discipline. Again, the conversation is shifting, and I think we no longer have to capture people's imagination. But I do want to start. I have a couple of remarks, and then happy to take lots of questions. And I know that questions are all over the place, and really want to make sure I spend a lot of time answering whatever thoughts you have. But I want to start with a couple of thoughts, and let me start with Governor Cuomo. So yesterday, in his presser, Governor Cuomo said governors don't do global pandemics, and blamed, among others, the World Health Organization for not sounding the alarm. And he also said, where were the experts? Well, as one of those experts, I think it's fair to say that we were probably screaming into a void, and probably doing so for the last 20 years. So every congressional testimony, every paper, every policy draft, every report, our entire discipline was focused on preparing for the pandemic. And we knew that there had been a fourfold increase in the number of emerging infectious diseases over the last couple of decades. This has been exacerbated by a warming planet, by urbanization, the vaccine hesitancy movement, antimicrobial resistance. On the deliberate side, the ability to synthesize novel agents, and the lack of any kind of meaningful global governance for emerging technology risks. So we knew all these things. We also, pretty much as a discipline, the one thing that we were most frightened of was that a novel coronavirus emerged. This is what we were most frightened of, and many of us were watching with deep concern starting in December But again, we were in this world where, how do we convince the world, how the keepers of the resources, those in charge of prioritization, that this particular threat was one that they should worry about? And that the challenge had been for really the last 20 years, that if we did all the things that we've been proposing and spent all sorts of money, the very best thing that could have happened was nothing. And that's a really hard sell when you're talking to a minister of finance, or even often a minister of health, who is looking at, do I build the type of public health infrastructure to be able to prevent, detect, and respond to a global threat like this, or do I save the kids who are dying in front of me from malaria? And often that was an either or, just because the resources weren't available for both. So that's a little bit about where we were coming from. And I have to say that I've been lecturing about pandemic preparedness and global health security for almost 2 decades. So maybe it was our fault. Like, maybe I wasn't convincing enough. Maybe I also suffered from a failure of imagination. And I have to say that I would often walk students through scenarios where dorm rooms were going to be turned into alternative care sites, where the National Guard would be called to assist, where mass quarantine might happen. But I have to admit that even for me, and again, I've been teaching this for 2 decades, every day has been surreal. So if I'm suffering from a lack of imagination, it's hard for me to imagine what decision makers are going through, and just how hard it might have been to listen to the experts or listen to the official declarations from the World Health Organization in January, and the discussions that were being had about the emergence of this novel coronavirus and what that might mean, and how to translate that into actionable policy. So I'm pushing back on Cuomo a little bit, but what I want to do is talk a little bit about global governance and what was in place prior to 2020. We have this lovely cutoff, since the first report of the coronavirus coming out of China was the very end of December. So pre-2020, there was a range of governance tools that were used for pandemic preparedness and response. We had a treaty. We have a treaty called the International Health Regulations. It's a unique international treaty. It's aimed at preventing, detecting, and responding to the international spread of infectious diseases. And it's designed to also try to avoid unnecessary interference with international travel and trade and protecting human rights. So it's a treaty that exists through the World Health Organization. It was an opt-out treaty, and nobody opted out, which means that every member state of the World Health Assembly, so all 196 state parties, are party to this agreement. So we literally have a treaty for how to govern emerging infectious diseases. We also have the Nagoya Protocol and access to genetic resources and the fair and equitable sharing of benefits and their utilization. So this is a protocol under the Convention on Biological Diversity, with implications and opportunities for human pathogen sharing and the equitable sharing of benefits that arise from the use of pathogens such as vaccines. And this came about out of discussions around kind of the social justice implications for vaccine companies that would get strains to access to viruses, the fear that they would then go away and create if they create a vaccine, and then the population that where the virus came from wouldn't then be able to afford it. And so the Nagoya Protocol applies to all genetic resources, but the Pandemic Influenza Preparedness Framework, which is yet another one of our frameworks, it is a non-binding instrument, and that governs the use of legally binding contracts to support this idea of access and benefit sharing regimes specifically for the sharing of influenza viruses with human pandemic potential and the benefits for their use. So looking at vaccines and diagnostics. So we have these agreements. We also had pandemic influenza plans. So these were specific to influenza, but planning by the World Health Organization, by countries, although they weren't necessarily updated very often, and then even a few of the megacities that had their own specific plans for how to respond to a pandemic. We had post the Ebola West Africa, we had the the reforms from the World Health Organization, the development of the WHO emergency program. There was also the development of the WHO's contingency fund for emergency and an expansion of the R&D blueprint. So research and development blueprint for thinking about what were the top 10 threats to global health and fear of pandemics, and how do we organize a research and development framework around that. At Davos a few years ago, something called CEPI was launched, and CEPI was created as a public-private partnership funded by some countries, not the US, but some countries and some of the major philanthropies and now private partners to focus on, how to speed up the development of medical countermeasures for diagnostics, and for vaccines, and then for thinking about the distribution that was a plan that would look like coming out of those. And so they were, for the last couple of years, focused on just a few of the threats that were identified in the WHO's R&D blueprint. So that included MERS, so cousin of COVID. It included Nipah virus, which is what the movie Contagion was loosely based on. So they were working on several of these initiatives and looking at kind of new technologies and how to fund that in an innovative way. The World Bank had established what we called the Pandemic Emergency Financing Facility. We call it the PEF. And this came also out of Ebola, West Africa, and the recognition that in order to effectively respond to outbreaks, you needed to have a rapid infusion of funds. And so they created this entire system of pandemic bonds. But I can tell you that those bonds just paid out 7 weeks after the declaration of the pandemic, and at a measly few million per each of the low-income countries that were identified under IDA. So I think we can say that the people who invested in those bonds made a lot of money, and the countries themselves are getting almost nothing. So something that was put into place but not operationalized terribly well. Also, in the last couple of years, we've had the development, the revision and development and fine-tuning of a series of metrics for capacity building and health security. So related to the international health regulations, and that is something. There's self-assessment scores that each country is supposed to report to the World Health Organization every year on how they're doing along a set of core capacities that were adapted from the text of the treaty. In addition to the self-assessment scores, the WHO launched something called the Joint External Evaluation, the JEE, which adapts not only the text of the treaty and the obligations that the WHO Secretariat thought that countries should meet, but also a set of metrics that came about from something called the Global Health Security Agenda, which was a multi-nation effort that was launched by President Obama in 2014, along with, it got up to, I think, about 65 countries and 3 international organizations. So the metrics that they put forward kind of got combined with the WHO's monitoring and evaluation framework to create this thing called the JEE. So we had scores that we've been keeping track of along 19 indicators in every country of the world to figure out how they were doing to be building their capacity to be able to prevent and respond to a pandemic. And then in addition to that, there were other academic efforts. There was one put forward by NTI, Hopkins, and The Economist called the Global Health Security Index that included the parts of the JEE, but also a whole bunch of other factors. And there were a number of different academic efforts by RAND, by Metabiota, by a bunch of different groups to put forward these indices for how prepared the world was for an epidemic, as well as what the threats were. So there were groups like EcoHealth Alliance, and there was a team of research institutes that were funded by USAID to look at spillover events and where the greatest threats were going to be for we could predict which species was going to be the cause of the next spillover event and where we should be targeting our efforts. So a lot of research, a lot of thinking had been going into this. And the work that we were doing in my center, one of the projects we were doing is we were looking to track the flow of funding. So we were trying to provide an evidence base for what actually worked in funding capacity building around the world, as well as where those best bets were. So we could go back to donors from the G20 and say, hey, that $8 billion that you gave to Kenya for laboratory capacity building had the following effect. And then we could actually provide the empirical data to support some of the anecdotal evidence that we were hearing from organizations like the World Bank that said, listen, it doesn't matter how much money you give, the host country, the partner country has to be able to, say, put a little skin in the game and to say, this is what we're committing. And that tracks with everything else we knew from global health and capacity building around the world. So there was real work that had been going on. Now, was it underfunded? Absolutely. Did public health link well with healthcare? It did in academic papers. Like we had published work looking at global health security linking with universal health coverage and how those two intersect. And it was language that was spoken by Dr. Tedros with the World Health Organization, but we never really integrated these two aspects as we thought about programmatic planning and capacity building. And did we underfund public health domestically? Absolutely. We've had 2 decades of drops in funding at local health departments in the United States. So, and were we a relatively small discipline? Yep. And in fact, as Jenny mentioned, the reason we held this conference last year is because we felt we finally getting to the point of having a community of practice. And it was time to start bringing together the experts who we knew were working and doing research with some of the decision makers to kind of build that bridge between research and implementation. So we were just getting there. And then we have this pandemic. So what happens? I think if you're all tuning into this webinar, it means that you're probably spending hours a day watching the news, reading everything you can. And so without, I think I don't need to reiterate everything that's been going on, but I think we can look at some of the bad and we can look at some of the good. And when we think about global governance, on the bad, there were certainly violations and breakdowns of global governance norms. So we saw one of the aspects of the international health regulations is the requirement to report any potential public health emergency of international concern by your national government within a really pretty short period of time between understanding that something's happening. Now, we know that you may have an outbreak in a village, and it might take months until the authorities in capital actually know that something's happening. So it's kind of hard to really judge and know exactly when did Beijing know that there was an outbreak of a novel coronavirus that had to be reported. We don't know, but I think it's fair to say that there were probably some delays in reporting of a novel coronavirus by the Chinese. There were definitely challenges in the WHO response, and that goes to some kind of critical notions of how WHO balances its obligations as a member state organization with its obligations to provide that evidence-based beacon on the hill. And every director general of the WHO for the last couple of decades has struggled with that balance. But we can talk a lot about that. We know that there were violations of the international health regulations, including, so not just the original reporting, but also under Article 43, it speaks to related travel restrictions. So the World Health Organization, when they declared COVID a public health emergency of international concern on January 30th, and even the meeting the prior week of the emergency committee to assess whether it wasn't whether they were going to declare it what we call a FIIC. That comes with evidence-based travel and trade recommendations from the emergency committee to the director general, which then goes out to all the member states. And the recommendation was and remained that there should be no travel restrictions in place. Now, clearly about 80 countries said, thanks, we're going to do what we want. And this gets at the kind of the very challenge of, in all aspects of international law, national sovereignty versus kind of global governance norms. So we looked at that. We've seen the clear lack of integration with universal health coverage and access to care, and even in the United States, seeing the disparities in who is dying from COVID. very much tracking with some of the disparities we see in access to care, and how do we fix that? We are looking at the fact that these metrics that we had been building and putting into place and carefully assessing and analyzing for the last decade have not actually been a terribly good prediction of success. So what do we replace them with? How do we actually measure capacity for prevention, detection, and responding to a pandemic? We've had some challenges with information sharing, although it hasn't been that bad, because actually countries and researchers have been pretty quick to specifically share genetic sequence data. But still, we have a lot of challenges in front of us, and there's going to be a lot of there's a balance between what scientists share peer-to-peer and what countries are approving to be shared, and where we're going to run into some tensions there. I've always suspected that when push came to shove, countries would nationalize. They would nationalize their manufacturing capacity. They would nationalize wherever they could if it meant they had to protect their own populations first. And we've certainly seen that. We've seen the nationalization of manufacturing capacity. France, India, all sorts of countries have been very quick to say, yeah, we make masks and we're not going to export them right now. Or we're not going to export this, malaria drug that we've been making forever and shipping to you because now you think it's going to be the cure for COVID, even though we know, no, it's not. So we've seen nationalization. We've also seen the breakdown of global supply chains, and now fears that we're going to see massive famine related to the breakdown of the food supply chains. And we clearly see the breakdowns in diplomacy and other norms. Now, on the good, we have seen some international organizations coming together in really unique and promising ways. So we've seen, for example, the Global Fund to fight AIDS, TB, and malaria has been allowing their country recipients to kind of tweak their funding and make it usable for COVID response efforts. Now, again, lots of discussion and analysis that we're going to have to do. There are fears that we are sliding back and we are causing incredible damage to our ability to fight polio, to fight measles, to all the global health program that's basically stopped and shifted to the COVID response. And so lots of interesting questions and challenges we have on how do we continue to integrate the response effort at the same time that we don't have excess mortality from all these other health threats like we often do see in localized outbreaks. We do see NGOs though supporting and informal collaborations coming together. We're seeing science diplomacy, again, that scientist to scientist collaboration, even when the countries themselves are not working together great. And we can look at the kind of the good and the coordination and collaboration through the WHO's solidarity trials. So many countries of the world, not the US, not China, are coming together to collaborate on clinical trials for antivirals, for vaccine development, and for the eventual prioritization and distribution of whatever countermeasures we do have. So we're seeing some really, really encouraging, great signs of collaboration. Again, what does that mean? The US and China are not a party to that. So I think when we can think about, just a few more minutes and then I'll wrap up here, but I think there's a lot of things we can look at for a potential path forward. And let me focus this on potential opportunities for US leadership, because I think there's all sorts of questions on kind of the future of multilateralism in general and where we go from here. And this is where I turn to Tony for his expertise. But on the US side, if we look at just global health diplomacy, there is a diplomatic window, although it is closing, where America can really build upon existing partnerships, whether it's through this global health security agenda, whether it's through the G7, the WEOG, the Australia group. There are opportunities to seize the initiative and set both the tone and the pace of diplomatic discourse to coordinate the next stage of the response. So whether that's looking at sustainable capacity building, real technical assistance with real money, because we've never actually had that kind of money in my space before. Recognizing and supporting subnational entities. we've been working for years with mayors and these kind of mayoral networks, and specifically with the Global Parliament of Mayors for the last couple of years on pandemic preparedness, because we always kind of thought that that's where the decision making was going to have to happen. And I think we're really seeing that, because it's mayors who have to decide how they're going to institute a quarantine, where their vulnerable populations are, what do they do with their first responders. So, but we've never done our planning at that level. The plans have always been at the national or the international level, and they haven't devolved to the subnational. So how do we now really think about our global governance, and particularly as the threat flows from, the risk flows from city to city often through international airport, as opposed to national capitals or ground crossings. So thinking about that, and then we also have to really look at, and there's a bit of a battle of influence going on, and who's going to win the hearts and minds of the lower and middle income countries. Who develops the vaccine first? Is it the Chinese? Is it the Americans? Is it the French? Is it this group at Oxford? And whoever gets it first, what does that look like for global distribution? And if the country that gets it first, are they going to trade votes in the UN for quick access to the vaccine? Is it going to be based off of need? Is it going to be based off of population distribution? I mean, there are all sorts of questions of, does Uganda or Kenya get the vaccine first? Even within a country, do the over 65 or people with diabetes or cardiovascular disease, do they get it first? Or does the military get it first? Or the royal family get it first? So lots of really issues that have never really been worked out very well in this space. We tried to work on that during H1N1, but didn't get all that far. So really important questions have to be worked out. We're also going to have to really assess the role of the WHO. So again, post Ebola West Africa, there were lots of reforms of the WHO for emergency response. But what comes next for this organization, particularly amongst calls for an entirely separate entity? We're seeing similar types of calls for a separate entity from the CDC. That's not my preference. I think we build and strengthen the organizations we have, but this is going to be an ongoing dialogue for a while. Do we need a new global workforce for emergency response? What kind of supervision or coordination is going to be required from the UN Secretary General for any type of complex event? Because we know that clearly any complex health event is more than just the health sector. So is it the responsibility of an organization like WHO to be thinking about the humanitarian response or the economic pieces? And we know that they don't have that capacity, but then who's in charge? And that's never been worked out well. So, but lots of questions for the WHO, particularly, we're not paying our dues. Now that's not going to come back and hit us until February. And I don't know if we'll still have the same administration in place. But what does it mean if we don't have a seat at the table anymore? And again, what are those questions? Like, what happens if the vaccine doesn't come from the United States, comes from somewhere else? And what does that mean for what kind of global cooperation and coordination we should be having as we try to protect our own population? I think there's a lot of questions on the future of the international health regulations. I published a piece 4 years ago about how we needed to think about not necessarily revising the treaty, because anybody who works in treaties knows that reopening the text of the treaty is just a nightmare for everybody. But I spent 15 years with the Department of State, or I did, working on the Biological Weapons Convention. And in the arms control world, we do RevCons every 4 year, every couple of years. For the BWC, it's every 5 years, and a review conference that brings together all the member states to really make the treaty fit for purpose and to come to a set of understandings about how to interpret each article as opposed to reopening the actual text. So we've been calling for RevCon for the IHR for a while now. In fact, I had a piece on this in November. So, can we actually really revise and revisit the international health regulations? Can we rebuild those norms? Can we look at sovereign states versus international law and information sharing? And is that enough? Is it enough to take the instrument we have and fix it? Or do we need to have a complete shift of thinking and look to entirely new governance norms? And I don't know. And again, this is where I might suffer from a lack of imagination, because this is the space I've been in, and it's hard for me to think about what the could-be's are without thinking first and about what we have. So that's where I am right now. I think we also clearly need to be doing a lot of thinking about resource distribution and governance of that. It's not just personal protective equipment, but also ventilators and oxygen and global distribution and those prioritization schematics for antivirals and vaccine. And do we need to move to having some type of international virtual stockpile? And I say virtual because you don't actually want medication sitting in a warehouse somewhere that's going to expire. So what does that look like? What do those contracts look like? And how do we get to a point where we have contracts that don't have, and I'm going to say this because in those pandemic influenza preparedness contracts for access and benefit sharing, there is a force majeure clause in all of those contracts. Those they're called standard material transfer agreements, the SMTAs, that say that, you know, the pharmaceutical company will, yes, you'll, in order to be guaranteed access to the strains, you can make your vaccine, you then cut a deal with WHO where you would, provide 20 million doses or something like that, that then WHO would be able to distribute in a fair and equitable way. But all of those contracts had a clause in it that said that for force majeure, that basically said, okay, this is all good, except if there's a pandemic, clearly where we can cut out of the contract. So how do we really start to build those international virtual stockpiles and close all these holes in truly what was, if I'm honest about it, a bit of a house of cards on the regimes that we had in place, because we knew there were holes in them. We knew that they would be challenged in a true pandemic, and now we're seeing that actually happen. And I think the final thing that I would love to see addressed is figuring out how do we codify the evolving relationship between the private sector and global public health. But one of the few good things that's happening right now is every single smart person in the world is solely focused on a pandemic, which means that we will hope. It's a bit challenging because it means that we have a lot of I've got a lot of armchair epidemiologists, including my husband downstairs, who I have got to figure out how to explain, well, no, there's a discipline to this, and this is what we do, and this is how we do it, and this is what it means. But I also fully anticipate we're going to see really interesting innovations. And right now, I'm actually working with a whole bunch of folks who come out of Silicon Valley and been working closely with the guy who helped found Google Cloud, who's been building all these really interesting tools for decision making on COVID. Now I come in as kind of the subject matter expert, right? But I don't have any of the tech background that these guys have. But how do we capture this? How do we capture this innovation? How do we capture the imagination of all of these different disciplines to strengthen pandemic preparedness, and figure out how do we really build this relation, again, codify that relationship as we move forward. So that's what I've got. Let me stop there and see if there's questions I can answer.
Well, that's a lot. That was an amazing tour de force of everything from the architecture to the international system to why it happens to where we can go from here. One thing you said that I want to highlight before we get to questions, and I don't accuse you of having a failure of imagination. I would never accuse you of that, but that phrase, because that was exactly what the 9/11 Commission concluded. It said that the reason the United States government did not connect the dots was because of a failure of imagination. And so when you said that, it eerily came back to me, and I was thinking, yes, because now we could probably anticipate another 9/11, but this isn't another 9/11. And so it raises the question, what aren't we anticipating that could be happening in the future? And it really, I think, invites us as an academic institution to try to instill in our students this nimbleness, this ability to think in an innovative, creative way so that we can foster imagination. And that's not an easy thing to do. Okay, let's open it up to questions. Kelly Young is going to shoot some questions to Dr. Katz. So Kelly, let me turn it over to you.
Sure, Tony. And I think this first question actually builds on what you were just just discussing. So this question is from Skip Horn, School of Foreign Service, class of '86. These outbreaks and pandemics seem to be unfolding more frequently and more quickly. Assuming we learn something from each situation to apply to future situations, what do you think is the primary takeaway from COVID-19? What have we learned that we must improve upon for the next scenario?
Oh, I mean, it's an excellent question. In theory, what's the phrase? It's like lessons observed as opposed to lessons learned, because who knows if we're actually learning them. But you're absolutely right. I mean, we have been just the last 15 years, right? From SARS, MERS, H1N1, Nipah. Well, Nipah was late 90s. We continue, Ebola, West Africa, the Marburg outbreaks. I mean, we see outbreaks all the time. And in fact, I mentioned this fourfold increase in emerging infectious diseases, but the WHO, again, prior to 2020, was tracking almost 7,000 signals every single month of infectious disease outbreaks around the world. And whether it was Crimean Congo hemorrhagic fever, to cholera, to influenza, but they were looking, and of those 7,000 signals, they were getting about 300 real events every single month that ended up being about 30 field investigations a month. So that means about once every single day, WHO was supporting a government that was for an outbreak investigation that was beyond its capacity to do itself, which means it's not like we weren't dealing with these things every single day. Now, what are the lessons observed? What do we do first? I got about a 30-page document I've been working on today to try to, and people keep telling me it needs to be shorter, and I keep making it longer because there's so many things we need to be doing and we're doing better. I think clearly, one of the things that I hope is learned from this outbreak is that we've been talking about global health security in the United States for a long time. Before that, we called it pandemic preparedness or public health emergency preparedness. The nomenclature has shifted a little bit over time, but it was almost always with an eye towards the thing that's going to happen somewhere else. So even in November, the reports that were coming out for CSIS had a Commission for Strengthening Health Security in America. It was all about the rapid response team we were going to put together to deploy somewhere else. But we almost never looked inside. We were one of the first countries to do one of these joint external evaluations. But we didn't do it really thinking that we were going to use the results to improve our national capacity. We did it more thinking that, okay, we're going to do this as a model for the rest of the world to show, hey, look, we can do this too, and isn't this great? But we're not doing this to line up with external donors to fix our lab capacity. We're just doing it to kind of highlight that. And I actually had a conversation with, at that time, the head of the CDC to say, great, what are you going to do with the scores? And it wasn't even there was no feedback loop that had actually been designed, because we always kind of figured, we got some problems in the US, but we're better than everybody else, so we're good. Now, clearly, this outbreak is showing where all the fault lines are. And, I would love to see one of the major things come out of this is we actually put resources into strengthening public health infrastructure in the country. We have 2 decades of losing epidemiologists at the state and local level. We saw this with Zika, where the mosquito control programs have been defunded and were basically non-existent, and suddenly we needed to think about mosquito control again, where we used to interview tuberculosis control officers. I spent years, it's not about me, but I have to tell you that people keep asking, where was all the research, where was the work that was done? This is what I do for a living, and I have to say that I've been funded enough to have a research center, but we've been scraping together pennies to do this type of work for 2 decades. And it took me 10 years to convince anybody to fund our research on quarantine, because it just wasn't something anybody was interested in. Now it's, even now, like, our research is being used. It's an evidence base that could be put forward on how to effectively do a social distancing measures, but we still can't line up and get additional funding for the future. So there is a bit of a disconnect here on how do we actually move forward, and where do we put our funds, where do we build capacity, and what does sustainable capacity look like? Because this field suffers from something. There have been a whole bunch of reports that use this terminology, and it was actually first put forward by Rakesh Chawla and Peter Sands in a report by the World Bank that called it the cycle of panic to neglect. And that is the cycle we have in this field, that every time there's an outbreak or like a MERS attack, everybody panics and they throw some money at something and they try to do something about it. And then, by a couple of years later, we're back into the cycle of neglect. And maybe our panic will last a little bit longer now that, again, we don't have to develop elaborate scenarios to convince people what a pandemic could do. But I'm certain that we're going to slide back into neglect. I just don't know how soon.
Kelly.
I'm going to try to say really positive, happy things.
Maybe we'll get a happy question. This is,
That was terrifying, but it does look like we are getting close on time, so I think we have just time for just one more question, because we know your time is valuable, especially right now. But so this question, the COVID-19 pandemic is enhancing nationalism and impacting democratic processes. Do you see an increasing or decreasing interest in intergovernmental regulations and cooperations within your work?
It's an excellent question, and it's really uneven. I think in some areas we're seeing incredible national cooperation and intergovernmental cooperation amongst some countries, and then clearly we're seeing other countries that are going more into, I wouldn't call it isolationism. It's not really what it is. It's just like it's a my country first. And we're seeing that with whether you look at the travel bans or the quarantine implications for even anybody who wants to enter into a country, and what that looks like, or we've seen countries kick foreigners out. Like, you got 2 weeks to leave. I think we've seen Hawaii do that too. Like, tourists, please get out of here. So it's uneven, and I don't know what long term looks like. I really don't. And honestly, I actually think where the vaccine comes from is probably going to dictate what cooperation and collaboration looks like, because I think the keeper of the vaccine is going to be able to guide whether this is done through a multilateral process, whether it's like whether it's WHO led, whether it is a One Belt One Road led process. So I think that's my guess, but I don't really know the answer right now. So maybe I end on a I don't know, because and that gets back to I've been getting lots of questions for the last couple of months, saying where's my crystal ball and what happens next, and we're building models just like everybody else, but at the end of the day I just don't know. I think we have to be hopeful, and that goes back to like our imagination and how we cope and how we get through next week, let alone next month. But I think we are seeing models around the world and if nothing else, we're learning from other countries and how they're responding, how to adapt their best practices, how to think about those practices in American context, and hopefully this will lead to more collaboration and cooperation as we underscore the fact that we really do have a collective threat, that we all are fighting the same threat.
Well, on that note, and I heard the word hope a couple of times, so that's a good word. I've been saying I don't know to a lot of people about a lot of things, and so that's just the honest thing to say. But hope is there, and hopefully we will learn. If anything, we can learn from our experiences here and apply what we've learned going forward. So let's thank Dr. Katz very much for an amazing overview. Please continue to look for her online, look for her publications. Special thanks to Kelly Young for reading the questions. And a final word of thanks to all of you who have been with us as viewers. And I said that was the final. One more person to thank. Eleanor Jones, Director of Alumni Relations for the School of Foreign Service. The idea of doing SFS online on topic was hers, and we will look forward to further sessions coming up. Dr. Katz, thank you again very much. I wish the best of you. Have a wonderful day. Stay well and stay healthy.
You too.